CLL generally is an incurable disease, as you may know, and we have a lot of new therapies out there for CLL, targeted therapies, pills, etc., which can all control the disease reasonably well, but cure rates, the deep CR rates and MRD undetectability rates are still wanting, especially when these new agents are used in monotherapy situations. And when patients progress after, let's say, ibrutinib or venetoclax type therapies, they actually have a very poor prognosis. They don't do very well at all for very long. So has been a need for newer treatments in that situation, especially, and that's kind of where CAR T cells come in. So JCAR17 or Liso-Cel is a CD19 targeted 4-1BB containing autologous CAR T cell product that we studied in phase 1/2 setting, and I presented the phase 1 results of that study. All patients on this study had to have failed a BTK inhibitor. It turned out to be ibrutinib in all of them, 100%. We presented data on about 23 patients across 2 dose levels. Essentially, there were more than half patients who had also failed venetoclax in addition to ibrutinib, and pretty much all patients had to have failed 2 or 3 lines of therapy, depending on what their risk category was of their CLL, meaning if they had TP53 mutation, etc., their poorest disease, they could have failed just 2 lines of therapy, including ibrutinib, of course. So, like I said, we treated 23 patients, 9 on dose level 1, 14 on dose level 2, and we found that this was generally pretty well tolerated. We look for specific side effects like cytokine release syndrome and neurotoxicity. We did find there were a lot of cytopenias, but that was just chemo-related because they all got lymphodepletion with fludarabine and Cytoxan. CAR T cells take about 3 to 4 weeks to manufacture, and pretty much about 17 of the 23 patients needed bridging therapy just to control their disease in the interim. Most of these bridging therapy patients were actually on dose level 2 as it happened, and more high-risk patients were on dose level 2 as it happened, so there was a little bit of skew between dose level 1 and 2. But in general, all of them were bad-acting CLL patients. And the CRS rates were very low, actually, on this study, with no grade 4 CRS events, and only about 2 out of 23 having grade 3 CRS events. The rest, there were about a total of maybe 70% patients who had some grade of CRS, and it was pretty much all grade 1 and 2 manageable issues. Neurotoxicity was also seen, about 30% or so in these patients, but only about 5 of the 23 had grade 3 or 4 neurotoxicity, again manageable and reversible. There were some tumor lysis syndrome as well because of circulating, lymphocytes, disease cells, and 3 of those 4 patients with grade 3 or higher TLS or tumor lysis syndrome were reversible. 1 or 2 did need respiratory and dialysis, but they were reversible. 1 patient had very spontaneous tumor lysis because of severe or rapid disease progression, didn't respond to CAR T cells, and that patient actually passed away with TLS actually still occurring. But died from disease progression, essentially. As far as responses are concerned, the overall response rate was pretty high. It was at 67-68%. That we saw right away at the first disease assessment at day 30, with undetectable minimal residual disease in the bone marrow as high as 60%, as well as early as day 30, and then these were maintained over time. So the longest follow-up, the median follow-up for the study thus far has been 9 months, but the longest that 3 patients have gone out to right now is about 15 months, so more than 12 months, and they're still in CR, complete remission, MRD negative. So the patients who achieved MRD undetectability seem to have maintained MRD undetectability thus far. There were about 5 patients who progressed overall on the study. 3 of those were Richter's transformation, but with no detectable CLL anymore, unfortunately. So that's unfortunate, and that's certainly an unmet need of being Richter's transformation across the board.